Asthma is a disease that affects about 2.4 million Canadians. Although many people have been told that they have asthma, not all are managing their disease or even realize that their condition is not under control. Today is World Asthma Day, and our experts are here to guide us in understanding the causes and treatments for this important condition and how to achieve asthma control. We will be conducting a live poll. We want to hear from you, so please log on to the information provided on the screen to participate. Joining us today is Dr. Samir Gupta, respirologist and scientist with the University of Toronto, and Carole Madeley, a certified respiratory educator with the Lung Association Ontario. We are also joined by Michael Nixon and Alexandra Lennox, two people who live with asthma. Now, Dr. Gupta, let me start with you. How prevalent is asthma today, and is it a condition that's on the rise?
So certainly it is a condition that affects a lot of people. If we think about prevalence data, about 8% of our population in Canada is affected by asthma. As you mentioned, that adds up to about 2.4 million Canadians. And certainly, based on data we've seen in the last few years, it is a condition that is becoming more and more prevalent.
And Carole, what kind of burden does asthma put on our healthcare system?
Yes, asthma certainly puts a lot of pressure on our healthcare system. A few years ago, a study reported that asthma costs Canadians about $2 billion in direct and indirect costs every single year. And a major driver of that cost is urgent care. Patients with asthma visit the emergency rooms across Canada about 70,000 times a year.
And is this because, Dr. Gupta, is this because asthma is a condition that is difficult for patients to get under control?
Actually, I would answer no to that question. So, in fact, if patients know what to look out for and are on the right therapy, asthma is actually a disease that in the vast majority of our patients we can get control of. From a sort of medical and clinical point of view, that's something that we see as a bit of a lost opportunity because there are many people out there who don't have good control of their asthma. And that creates morbidity. These patients are visiting the emergency room, they're on lots of medications, they're sometimes requiring urgent medical therapy. We have guidelines that have been produced around the world, including in Canada, that very clearly delineate what constitutes good asthma control. And it's not rocket science, it's a series of questions. It's a series of questions that patients and doctors should be aware of. And it's a series of questions that we should be using clinically to determine which of our patients have good control versus don't have good control, and take the steps that are necessary to achieve good control in our patients who don't have it. So basically, to present that to the audience, there are 6 basic questions that I want to go through that patients out there should be asking themselves and should be expecting to hear from their doctors. So the first is, have you missed school or work or your other activities due to your asthma? Are you woken up by asthma symptoms on average 1 or more nights a week? Do you have asthma symptoms on average 4 or more days of the week? Have you used your reliever or rescue inhaler, as we call it, on average 4 or more times a week? Has your asthma prevented you from doing physical activities like exercise or sports? And have you had a recent flare-up of your asthma requiring you to seek urgent care, emergency room care, or with your doctor? If you answered yes to even one of these questions, any one of these questions, that means that you have poor asthma control.
The Lung Association recently commissioned a national survey reaching out to 1,000 Canadians living with asthma and asked these 6 control questions that Dr. Samir Gupta just mentioned. And here's what they found. 75% of people have asthma flare-ups. 65% had difficulty with physical activities due to their asthma. 35% use their reliever inhaler more than 4 times a week. 32% have asthma symptoms on more than 4 days a week. 28% woke up with asthma symptoms at least once a week, and 11% had actually missed work or school due to their asthma. 90% of people answered yes to these questions. That means that 90% of people across Canada do not have good control of their asthma.
And what's compelling about this is that we have had data presented previously from surveys and research studies as well. These numbers are even higher than what we've seen previously. And I would say that the most sort of worrisome part of this report is that if you use guideline criteria, as Carole mentioned, 90% of patients actually don't have good control of your asthma. their asthma. But if you actually go out and ask these patients, how do you feel about your asthma? Do you feel that you have good control of your asthma? 93% of patients will tell you that they actually believe their asthma is well controlled.
Oh, wow.
And so that's, it's almost a reciprocal in terms of the numbers. And that speaks to a gap, what we consider a gap in expectations, a gap that exists at the patient level, but also at the level of the healthcare provider. And I think that, we're also as healthcare providers sometimes guilty of overestimating the level of our patients' asthma control. Patients also tend to have a sort of low expectations of their asthma control. So they habituate to their symptoms and they sort of live with their symptoms and they accept that I may just have to, accept these kinds of perhaps arousals at night or requiring the rescue puffer quite often or living with cough or wheeze and sort of consider that normal and part of life. Whereas in reality, they should be flagging that to their doctors and saying, I'm poorly controlled, because there are things we can do about that.
And that's a perfect lead into our poll question. So we want to know, is your asthma well controlled? Go to the webpage carp.ca/asthma to participate. And we will be monitoring the results live during the rest of our program. But Carole, it strikes me that there are many conditions that mirror the symptoms of asthma. So how do we know if we have asthma?
Asthma can be diagnosed using a very simple tool called a spirometer. And this here is a spirometer. And I'm going to demonstrate what you do with the spirometer. Spirometry tests can be done in family doctors' offices. They can be done in hospital pulmonary function labs. The respiratory therapist will ask the patient to take a really big breath in and blow the air out hard and fast and keep blowing and blowing till they feel like their lungs are empty. So I'm going to demonstrate that really quickly. So the respiratory therapist will ask the patient to do a minimum of 3 tests. And if these 3 tests are acceptable, then they'll go on to give the patient some puffs of a medication called the reliever medication. They'll give the puffs of the reliever. They'll ask the patient to go to the waiting room for a few minutes, maybe 20 minutes or so. They'll bring the patient back into the lab, and then they'll repeat the tests. And if the tests show that there is improvement in the airflow obstruction, therefore this will help the physician diagnose the asthma. Now, sometimes we need further tests if the spirometry test is not sufficient, and therefore the patient would be referred to a hospital or to a pulmonary function clinic.
And Marissa, this is a tool that we actually use every day in our respiratory clinics, not only to make the diagnosis of asthma, but also to monitor our patients' asthma to see how their lung function evolves and changes over time. We were involved in a recent study actually where we tried to take a look at in patients who have a diagnosis of asthma, how often have they actually had this spirometry type of test to formally diagnose that asthma? And as it turns out, only about half the patients who have been diagnosed have had this test done. And that's a bit surprising because you're wondering how that other half got diagnosed. And in most cases, those patients were diagnosed either because of physical exam findings or because of the history, the story that they told. The challenge with that, the problem is that when we take these patients who've been diagnosed with asthma and we actually then formally put them through these asthma tests, we found that a third of them didn't actually have tests that showed asthma. And so what we're seeing there is probably many patients who were incorrectly diagnosed. In some cases, patients who had asthma that probably now has become much more stable and is not being detected on the tests anymore. But the main concern about this notion of diagnosing asthma without the proper tests is that we did find other conditions that were in fact being missed and being called asthma incorrectly. And examples would be, reflux, acid reflux, sinus disease, and in some cases we found actually some cardiovascular diseases that were more serious that were sort of masquerading or mimicking asthma.
Okay, but the asthma would cause the spirometry results to appear abnormal. If you would, what is the actual process that's happening in your lungs that defines asthma?
Right. So, from a scientific point of view, we think about asthma, we define asthma in different ways. So first, from the symptom point of view. So we're looking for a history of respiratory symptoms that occur. They tend to vary in intensity over time. and they tend to be triggered. So they tend to be sort of on-off in nature in many, many patients. We also, of course, when we're trying to make this diagnosis, we look for objective testing, so spirometry, and as Carole mentioned, in some cases, you do need more sophisticated testing than the spirometry. And you're looking with the spirometry for a change in lung function after administration of that bronchodilator, that puffer that opens up the airways. It really should only do that in a patient with asthma. And so if we see that significant improvement in the numbers after that puffer, that gives us the diagnosis. Alternatively, we also can make the diagnosis with changes in these values over time, which is something we see in asthmatic patients, but not in other patients. Finally, at the level of the lungs themselves, we also have a lot of information about what the biology of asthma looks like. So what we look for in the lungs is really signs of what we call chronic inflammation of the airways. The last point I'll make is that sort of we have these criteria around what asthma is and how to diagnose it. But asthma is a very heterogeneous disease, and by that I mean that it really can manifest in different ways in different patients. So many of you in the audience and watching may have mild asthma, and when we talk about mild asthma, we're really, in many patients, talking about asthma that is only manifest, for example, at certain times of year when their allergies are active, or perhaps when they have a cold, their asthma comes out. On the other hand, and sort of the other end of the spectrum, many of the patients that I see in my clinic have severe asthma. And here we're talking about patients that have, year-round symptoms, often despite being on the best therapies. We talk about symptoms, we're generally talking classic symptoms. We're talking about cough, shortness of breath, wheeze, tightness in the chest. Symptoms, all of these can occur, or only a few of them can occur. It varies by patient. They can occur together or separately. Sometimes they occur as a sort of attack, a sudden attack after exposure to something that irritates the lungs. At other times, they may be sort of more chronic symptoms, like a chronic cough may be a sign of asthma, or a chronic wheeze. Often patients will tell me they wheeze at night, and it's not an attack per se, but it's a manifestation of asthma that they often experience every day.
Now, Carole, you brought in a model of the airways to help explain this to the audience. So why don't you demonstrate that for us?
Yeah, so this is a model of a normal airway, and you can see that you can easily see through the airway. So when the airways open like this, the breathing is easy. And around the airway, we see these tiny muscles, and these muscles are very sensitive.
And what I want to do is I want to contrast that with what an airway looks like in asthma. And so you've got these two models here. You've got this airway that Carole demonstrated, the healthy airway that's has a nice open, what we call lumen or opening, where the air can move in and out. And then you've got the airway from a patient with asthma. The first thing you'll notice is that it's very red, and that's a sign of inflammation. Okay, infiltration of cells, which is really inflammation in the wall of that airway. Because of that inflammation, you can see that thicker wall means that there's a smaller opening. And that opening is where the air moves in and out. So you can already get a sense of how it's going to become difficult for that patient to move that air, how they might start feeling tight and short of breath. I'll also note that the muscle that's within this airway wall is not only thicker, but it's also more twitchy in patients with asthma. And that twitchiness is what often leads to these asthma attacks and these classic symptoms. So again, if you breathe something in that's irritating, whether it's an allergen or just something irritating to your lungs, as a patient with asthma, this airway will get irritated and that muscle will twitch. And when it twitches, that closes this airway right off. And that's going to cause shortness of breath, cough, wheeze, and tightness. The last thing I'll point out is that you can see some mucus in the middle of this airway. And that mucus, patients will often tell me that when they're having their asthma attacks, they cough up mucus. That mucus is, again, a byproduct of that inflammation. And it's yet one more way that this airway is being occluded, or the lumen of the space in that airway is being reduced. And one more thing that's preventing that air from moving in and out nicely when the patient's trying to breathe.
So then what are some of the other conditions that can affect asthma?
So, there are a number of other conditions that I'd say travel with asthma. In some cases, asthma makes some of these conditions worse. In other cases, some of these conditions can actually make asthma worse, but they're often seen in patients with asthma.
Mm-hmm. And perhaps you could give us some examples, Carole, of conditions that could exacerbate asthma?
Yeah, one of these conditions are allergies. You know, this time of year we've got the tree pollen. Some people might have allergies like dust, pet dander. So what happens to a person that has asthma is when they come in contact with that allergy, then it causes that inflammation in their airway, and it makes it difficult for them to breathe, and the inflammation also leads to the mucus production that Dr. Gupta just finished speaking about. And then a person ends up with an asthma attack.
And you know, a lot to that, another thing to keep in mind with the sort of the allergic frame of mind is that people with allergies will often also have something called allergic rhinitis, or inflammation of the nasal cavity from their allergies. And that means the sinuses, the nose, and what we call the upper part of the airway. Now, what this will cause in terms of symptoms is a runny nose, a drippy nose, sometimes an itchy nose, but also mucus that drips down the back of the throat. And we call that postnasal drip. When you have this kind of inflammation in the upper part of the airway, because it's continuous, this often causes some inflammation in the lower part of the airway, and that can trigger the asthma. The other thing that's important to note is that this postnasal drip can in itself cause a cough. And this is the type of cough that particularly gets worse when people lie down. And what's tricky is that, you know, cough is also one of the cardinal symptoms of asthma. So clinically, sometimes it can be very tricky if your patient has postnasal drip to figure out if their cough is from their asthma or their postnasal drip. And so both from a symptom control point of view and from the point of view of figuring out, you know, where do you direct your therapy, very important to disentangle those two things and to get that allergic rhinitis or even non-allergic rhinitis, you can get rhinitis without allergies, to get that under control.
And is it true that acid reflux is another thing that can sort of play a role in asthma?
Absolutely. You know, reflux is another one that's very high on our radar as docs when we're thinking about our patients with asthma, particularly the ones who don't have good control of their asthma. So we know that everyone knows that our stomach produces a lot of acid, and that's to kill the bacteria in our food and to help digest that food. That acid should normally stay in the stomach and digestive system, but it unfortunately often works its way back up in the wrong direction and finds its way into the esophagus, which is the tube that takes the food from the mouth down into the stomach. If it does go up the esophagus, people will often complain of what's called heartburn, and so sort of burning feeling in the stomach that comes up the chest. We call that acid reflux. The challenge with acid reflux is that if it's severe enough, that acid can actually find its way all the way into the lungs, and you can imagine can be a very inflammatory, irritating stimulus to the lungs, and particularly in a patient with asthma, can trigger an asthma attack. Even if that acid doesn't quite reach the lungs, that kind of reflux can trigger cough. And so again, we get into this dilemma in our patients with reflux who are coughing. Is this cough because the reflux is triggering the asthma? Is this cough the asthma itself? Is the cough caused by the reflux? And so again, very important to disentangle those to guide therapy.
Dr. Gupta, what can asthma sufferers do to better manage their symptoms? Are there strategies for prevention? What can you share with our audience?
I think prevention it's something that we don't talk enough about, and we're probably guilty of that, you know, in the medical field as well. But you know, prevention is sort of the cornerstone of asthma management, and there are many things we can do from a prevention point of view that you know, long before we even consider medicines for asthma. We talked about allergies, so patients with asthma often have allergies, and we call that allergic asthma. If they don't have allergies, their asthma is often triggered by irritants, so it's irritant-induced asthma, and sometimes people have both. And so, you know, from the point of view of allergies, I think it's particularly important because that's something that we can address usually more easily than irritant triggers. So people should be looking out for symptoms of allergies, and it's typical symptoms that people are aware of. You know, sneezing, runny eyes, red eyes, runny nose, itchy nose. If you have these kinds of symptoms, even if you don't necessarily have asthma symptoms around that trigger might also be driving some inflammation in your lungs and making your asthma generally worse. So very important to recognize that you may have an allergy, and if you have those kinds of typical allergic symptoms, seek out the help of an allergist. Get yourself tested, figure out what exactly you're allergic to so that you can modify your environment to avoid those exposures. And then you could also consider things like allergy shots.
You mentioned irritant triggers. What are some other triggers that patients should be aware of and may not be aware of?
I won't necessarily give you sort of a single trigger, but I'll talk about a category that we often worry about in the healthcare profession, and that's That's the notion of work-related asthma. And so it's an entire category where we can consider people might be exposed to allergic triggers or irritant triggers in the workplace. And what often happens is that people won't notice that their asthma is getting worse in the workplace, and that can be driven by something in that environment. And there are many potential things in that environment that could be driving that. What we ask our patients, so we certainly like to ask what occupation they're involved in, because different occupations have different risk profiles for work-related asthma. But we try to ask our patients to notice patterns. You know, is there a specific task you're doing at work that might trigger you to have symptoms? Do you notice, for example, that you're better in the evenings when you're home from work, or better on weekends? Some of my patients will tell me, you know, the classic thing is they go away on vacation and their asthma kind of disappears. And then it really triggers, you know, what is it in your day-to-day that's different? And then you start thinking about work-related asthma. If this is something that you haven't thought about, think about this, you know, think about that relationship and that pattern. And if it exists, very important to explore the workplace, you know, what might be here that's driving this, and explore this with your doctor. And it's a bit of a detective job sometimes to find this, but if you can find it and eliminate that exposure, we can gain dramatically in terms of asthma control. And
other than, and we'll get to the panel shortly, the rest of the panelists shortly, but other than avoiding triggers, what are some other ways to manage your asthma? I think one of the things that isn't used enough out there, and we'd love to see it used more, is the concept of self-management. So, we've been talking about self-management in asthma guidelines for over 20 years now. But the reality is that it's still rarely done. And what I'm talking about is a tool called an asthma action plan. So it really is just a simple one-page piece of paper that the healthcare provider produces for their patient with asthma. And what it does is it provides instructions to the patient on what to do when their asthma symptoms worsen. Now, this is a tool that's usually designed in what we call a traffic light configuration. And so there's a green zone which describes, this is good asthma control, and it reiterates what your usual therapy should be. There's a yellow zone that indicates, you're having an asthma flare, here's what you need to do. Usually it means increasing your inhaled medications temporarily. And there's a red zone, and that red zone really indicates, these are dangerous symptoms, find your way to a healthcare professional, get urgent care. What this kind of a plan enables our patients to do is to self-manage, and it really empowers patient. And the idea here is that if you're worsening, you're often going to worsen very quickly. You may try to contact your healthcare provider, but there's a period of time before you hear back from them where you really might not know what to do. And what this tool does is it empowers you to take certain steps yourself before that asthma gets to a point where it will need urgent care and perhaps more aggressive therapy. There have been many studies of this kind of an approach, this asthma action plan approach, and we know that if we give our patients this tool, they will come to the emergency room less, they will have less symptoms, they will have a better quality of life, they'll be hospitalized less. So all things that are really important to us as healthcare professionals and to patients. But the reality is that if you go out and measure, is this happening in the field? In a recent survey, 4% of healthcare providers said that they consistently provide their asthma patients with an asthma action plan. And if you go out and look at charts in actual clinics, 2% of our patients with asthma have actually received one. So it's not something that we're taking advantage of. And I would say that if you're out there and you have asthma and you haven't received an asthma action plan, you can print a plan from a URL that's on the website and bring that to your doctor and ask them to fill it out for you. Mm-hmm. Carole, what about medications? What are some of the key medications that people are using to treat asthma?
Yeah, there are many different inhalers to treat asthma, and we can't go into all the different inhalers that are out there today and all the different devices. However, I do want to talk about the two major categories of medications that are really important in the treatment of asthma. So one of the categories are the relievers. So the relievers of medications do exactly that. Often people call them their rescue medications. They take this reliever medication and they're bronchodilators, and when they take it, it actually helps open up the airway and they feel so much better. They can feel they can breathe easier. So those are really important to have reliever medications, and people should carry their reliever medication on them, but reliever medications are used as prescribed and they're used when you have symptoms. So you shouldn't just be taking it for no reason. You should be having symptoms and you use the reliever medication to relieve your symptoms. The other large category of medications are we call the preventers, or they're controllers. And the preventers, well, they help prevent the asthma attack in the way where they help decrease the inflammation. And preventers are often used on a daily basis. So my best recommendation is for people to use their medications as prescribed by their healthcare provider.
Yeah. Are there any side effects to these controller medications that Carole brought up?
You know, there are side effects, and I think, you know, probably the most important category that we should address and talk about is inhaled corticosteroids. I mean, that is sort of the cornerstone of controller medication in asthma, and that concept of steroid is also the concept that people worry about the most in terms of side effects, and so we should address that. And you know, we know, in fact, from our surveys that up to 14% of patients with asthma in this country don't take their medications as prescribed. And so that's a problem. And often doctors don't know about that. You know, sometimes I'll ask my patients and they'll sort of gloss over it, but if you really push, they'll tell you I'm not using it every day or I'm not using it as prescribed. And a lot of that has to do with fear of steroids. And the sort of downside of that we see is that there's a lost opportunity for improved asthma control because that's what those steroid medications are for. What I generally will tell my patients is that the reality is that the medication is designed as an inhaled medication because it's designed to get in through the lungs and act in the lungs. Very little of that actually gets into the system and affects the rest of the body. So very little of that is absorbed. That being said, you know, there have been studies in patients who take moderate or high doses of steroids and who have taken them for a long period of time that show that there can be some side effects from these steroids. There's always a risk-benefit ratio, and what I always try to explain to my patients is that there are many, many downsides of poorly controlled asthma and many risks. And asthma can be a life-threatening condition if it's not well controlled. And so it's always about balancing the small risk of side effects with the benefits of having good asthma control and not having severe attacks and ending up in the emergency room and all these other concerns. And so I would say that, you know, that risk profile, that discussion about risk needs to be personalized. You know, what are the doses that you need? How long do you need them for? What is the pattern of your asthma? How severe is your asthma? And how do you balance those things? And I would encourage everyone to have that frank discussion. You know, don't take the prescription and then sort of minimize your use of the medication. Address it. You know, your doctor will be open to this discussion around what are the side effects of this medication? You know, what can I expect? Short-term side effects, long-term side effects, and what are the benefits? And make that decision yourself after understanding those.
The inhalers, are they intuitive? Are they easy to use?
They're easy to use once you're used to them,
Yeah.
but the challenge around that is that there are many different devices on the market, and particularly in the last few years, we've had a sort of explosion of new devices. And so we will often find patients who are not taking their inhalers correctly. The best story is the patient who for years was not taking the cap off the inhaler, right? So this happens, right? And the lesson is that you absolutely need to go through your inhaler technique with each and every patient. And as a patient, if you haven't had somebody show you how to use that inhaler, you know, ask for that. Ask your doctor, your pharmacist, any of your healthcare providers. Most of them have the skill set to show you how to use your inhaler. And if you'd like, you can even look at this online. And there's no harm in getting a refresher every now and then because you might be forgetting some of the finer points. And there are videos of this that, in fact, again, you can find a link on the webinar site to a series of videos on how to take these different devices.
Carole, you're a certified respiratory educator. What is your role in helping people with asthma?
So a certified respiratory educator is a healthcare professional who has gone on to do further training and get education and learn how to self-manage and learn how to manage diseases like asthma and chronic obstructive pulmonary disease. So by working with your certified respiratory educator, they'll teach you the tools and give you the skills so that you can better self-manage your disease. And the Lung Association has a lung health information line that is staffed with certified respiratory educators, and our phone number for the lung health information line will be posted on the website.
Terrific. Well, that was a lot of very useful information. At this stage, I want to turn to the patients on our panel and ask them to share some of their experiences with asthma. Mike, I'll start with you because you were diagnosed with asthma at 4 years old, and you've been managing your condition ever since. Tell us about your experience.
Yeah, well, 4 years old, I think Mom probably realized as a nurse that there was something wrong not long after I was born. For those first few years, I spent a lot of time in the hospital with a variety of different colds, and it always had to do with the chest. And so the diagnosis was made, and at that time, it was really simply a matter of listening to your GP in terms of what I'm going to do and how I'm going to take care of it. A couple of years later, I think by the time I was 6, it just happened that I was at a friend's party, birthday party, had a bit of peanut, and had a terrible reaction, was hospitalized, and my doctor sent me for testing skin tests, and it ended up that I was allergic to a lot of foods, a lot of environmental functions, and Mom started to put these things together. You know, it wasn't just outdoors, it was food, and they would get worse. My condition would get worse when that happened. There was very little that Mom was able to do in order to manage it. I had my diagnosis before inhalers were actually developed, and I recall going every week, twice a week for injections. I remember taking pills to help with my reactions with the asthma for a number of years. What I remember the most, and I guess we all appreciate our parents in different ways, I remember the effect that it had on Mom and Dad. I was the only one in my family, fortunately, that had asthma as a youth, but I remember Mom sitting with me on the side of my bed, and this was the greatest resource that we had, doing exercises, breathing exercises that the doctor had taught us. And Mom, I appreciate it now. Mom would be there all the time with me, helping me to breathe through this. Fortunately, I guess our memory is selective. I remembered that, and that was a bonding thing. I don't remember so much, I think, what we as parents, I have 2 asthmatic children. I remember what they went through in the hospital when they were first born. We don't remember that. What I do remember, though, is around the time I was 10, we moved. We moved to the East Coast, and it just so happened that for whatever reason, my conditions started to get better. Was it environmental? Was it the fact that I was growing to puberty and my body was changing? Not too sure, but I was there for a number of years. We came back to Ontario, and my asthma, for all intents and purposes, I thought was completely under control. I thought it had gone away. It was only about 10, 15 years ago that I realized, no, that's not the case at all. You live with asthma in different ways, and I've noticed a resurgence of that, particularly environmentally triggered right now. I know during the winter time, I've just finished, as a matter of fact, controlling my asthma with my controller, and that would be for a number of weeks, and it oftentimes happens during bizarre weather. I mean, it's raining outside right now, and I can feel the bits of something going on. So it stays with you, and it does. We never developed that plan, Dr. Gupta, that you talked about. But I guess maybe in our own way we did for our kids as they're developing based on experience.
It's amazing you tell your story. There's so many different triggers that can spark your asthma. So thank you for sharing your story. Alexandra, I'll turn to you next because you have a very long and complicated history with asthma. You've also been a patient of Dr. Gupta's for 8 years now. So why don't you share your story?
Well, thank you, Marissa. As you've just heard, my name is Alexandra Lennox, and I'm 62 years old. But I'm happy to report that for the last 2 years, my asthma is finally under control. I consider my 50s to be years from asthma hell. For many weeks, often even months, I would be totally debilitated with asthma and its side effects. Now, my asthma is a bit different. It's triggered by 2 things. And the first of all is if I get an upper respiratory infection, like a cold or a cough, or even a sore throat or a viral infection, it will invariably become a bad chest infection, and that will trigger my asthma. But secondly, and most importantly, about 50% of my asthma flare-ups were due to severe acid reflux. And I developed this in my late 20s. So what would happen is that the acid, as Dr. Gupta has explained, can sometimes go into your esophagus or your lungs. And this would happen to me, and it would trigger my asthma. Now, unfortunately, when I get a bad chest infection, it means that I'm invariably sick for a fair amount of time, and I need a lot of steroids and usually several courses of antibiotics. So this causes a vicious circle because I need the drugs to calm my asthma down, but what happens as a result, the drugs actually start my acid reflux playing up. And with that worsens my asthma. And then I get all sorts of side effects. I will get inflammation of the stomach lining. I can get inflammation of the esophagus. I can get some ulcers. I'll get a chronic cough. I will get a debilitating sore throat. And I will constantly be clearing my throat going, And also the other thing is that it's made me very prone to getting candida infections. Now, candida infections can make you sick, very sick, and make you feel very unwell just on their own. So fortunately for me, 8 years ago, I became Dr. Gupta's patient. He's my lifesaver. And as a result, Dr. Gupta very quickly surmised that in order to get my asthma under control, we would have to get the acid reflux under control. So he referred me to a superb gastroenterologist, and the two of them together, they worked very closely together for me. They devised a fairly aggressive treatment plan to get my asthma under control. So I had an operation, amongst many other things, and it's called a Nissen toupee. And a Nissen toupee, what the surgeon does, he basically lifts the top part of your stomach, he wraps it around the esophagus in order to create the flap. Now, what the flap does, its job, is to prevent the acid from going into your esophagus or into your lungs. Unfortunately, with me, the first operation went wrong. Many things went wrong, as Dr. Gupta knows. But I had a redo, and the second operation has been a success. So what's happened as a result is that I now no longer get asthma as caused by severe reflux. What has happened as a result, not only has it cut down my asthma by about 50%, but what is hugely important, it allowed me to get much stronger physically. And in getting stronger physically, I've been able to fight off chest infections better, but most importantly, we're finally able to get the rest of the asthma under control. So in order to stay healthy and basically have the asthma under control, of course I need Dr. Gupta to be my respirologist, but I need to be vigilant about taking my daily drug therapy, which are controllers, and I need to take these on a consistent basis. But more crucial probably than most things, I need to execute my asthma action plan if something starts going wrong. And I'm very fortunate because both Dr. Gupta and my family doctor, who I work closely with, they seem to trust me. And they're accessible by email very quickly. And by trusting me, what's happened is that it's allowed me, when they prescribe the drugs and with my asthma plan, I'm able to have quite a lot of freedom with the asthma plan. So I'm able to increase the dosages in my rescue inhalers as well as in my rescue controllers. And if I need, I can add some other controllers. And also, quite important in my chest infections, I can start antibiotics on my own, and I can start steroids on my own. So this has resulted in, if you take all of these factors and you become a good manager, and that you really do get a sense of empowerment when you are able to control your asthma and prevent it from getting worse, it has meant that I have finally got my life back, and that I'm able to travel and do things that I love. I've just come back from Australia and Tasmania, which would not have been possible for me without a proper action plan and everything else falling into place. And I can now also go to the cottage in the summer and not be concerned if things start going wrong, because I know I can self-manage my asthma action plan.
Well, that's delightful, and also a testament to the importance of having a good respirologist in your life.
Yes.
and a good family doctor. It was interesting as you were talking about some of your symptoms. I was looking around the room, quite a few people nodding their head as if to suggest that they also share those symptoms with you. So I suspect we'll have quite a few audience questions now. Thank you for sharing your story. Why don't we open the floor? Who has the first question?
Hi, my name is Ray Balden, and I'm retired. My former occupation was a director of human resources. My question is pretty simple. So with asthma, what should I expect as I age?
Okay, I can take a stab at that. I think, we're learning more and more about, this concept of asthma as a chronic disease. So there was certainly a time where we considered asthma a disease that once you have it, you always have it. But more and more, we're recognizing that asthma, it does tend to evolve over time. And so the sort of classic pattern is someone will have childhood asthma, and they'll often outgrow it in adolescence. And they'll often then have a long period where they have very few asthma symptoms or sometimes no asthma symptoms at all. They'll sort of forget they even had the disease. And then later in life, they may get the disease again. And often I'll be seeing patients, in 40s, 50s, 60s, diagnosing them, quite late. But often if you ask, they'll say, well, yeah, I did have it as a child. I do remember having it as a child. In that period of time where they didn't have symptoms, it's maybe just semantic whether they had asthma or not. But what we're finding in recent studies is that there are periods of time where asthma is very quiescent, where even if you test someone for asthma, they don't have it. So for all intents and purposes, they don't seem to have the disease. More specifically to your question, if you do have asthma at a certain age, can we predict its evolution over time? And the answer to that is very difficult to do. If someone predicts it for you, I'd say don't believe them, because asthma can go in many different directions. I've seen patients who started off with very mild disease and I expected them to stay mild, but they became very severe. I've seen the other end of the spectrum where someone came in very severe for years and we had them on the best medicines, but we thought we might just be able to maintain them. But over time, they improved and we were able to reduce their medicines dramatically. And often I will see patients who have a very cyclical pattern. And this is over years, 2 or 3 years where asthma is poorly controlled. And Mrs. Lennox had this situation, particularly related to the acid reflux, I think. But then a period of time where asthma is much better. And there's a cyclical nature to it that we don't always understand. Sometimes it's related to the environment, work exposures, home exposures, travel patterns, maybe stresses at work, different things that drive it. But at other times, we really can't explain it. Is it a hormonal thing? What are the different factors that might be influencing that cycle? So it's very hard to predict.
And Mike, I would go to you next, just because you mentioned when you were sharing your story that your asthma has fluctuated. How did it, as you aged, how did it affect you?
I noticed it subtly. It would always be around times when I seem to be affected by a cold of some sort. As time's gone on, the last few years, I can almost predict that by the time it gets to about December, I'm going to start using my inhaler, my controller. And it's much more subtle than it was when I was a child, much more subtle. But I think to the point that both Carole and Dr. Gupta have mentioned in terms of developing an action plan, I think in my own way, perhaps based on my childhood experience, I put into effect my own action plan, making sure that I'm very dedicated to the inhaler itself. I've also, excuse my back, but I've also made sure that within our own house, the environment is such that is friendly as well. So there are asthma and allergy-friendly products, bedding, floor products, that sort of thing. And as best as possible, we've tried to migrate towards those. And I mean, it does help, it seems.
Did you want to add something, Carole? What have you seen from some of your patients?
Well, I like I mentioned, I think it's really important to know your triggers, because then you can avoid them. And one of the first things that we do with asthma is environmental control. So you look at, what are your triggers? How can you avoid them so that you don't have asthma symptoms? And then we move into medication use as a next step if required. So I think as you've learned many of your triggers, you've got to know what to do, what to avoid. I think it's really, really important.
Is there how about a second audience question?
My name is Jean Harris, and I worked 40 years in healthcare. And my question is red wine or other alcohol triggers
For asthma.
for asthma?
Gina, I think if you look at a textbook in terms of the triggers for asthma, you'll see a frighteningly long list. And so, and that's my experience in practice too, is that all of my patients have a different set of triggers, and it's unique to the person and their environment. Red wine has been described as a trigger for asthma. It's thought to be related to the sulfites in the red wine, and those are found in some dry fruits and seafood as well, and so people will describe symptoms. It's thought to cause sulfur dioxide release, and that sulfur dioxide can trigger the asthma. So there is a mechanism whereby red wine can trigger. I've only had one patient ever who had that trigger, so you might be unlucky if that's one of your triggers and you enjoy red wine, but many things can trigger asthma.
We have a question from a CART member in London, Ontario now that we received online, and it reads, I had asthma as a kid and it wasn't a problem for many years, and now I feel like it's come back. Does this make sense, and what should I do?
I think it comes back to the first question and the cyclical nature of asthma.
Yeah.
And so we will often see childhood asthma that people outgrow, and then it comes back. And people often have a hard time believing it when you diagnose it, because they say, no, doc, I outgrew my asthma. So, but did they ever really outgrow it? Was it there, was there a very subtle asthma that was there? Maybe not enough to cause symptoms, but if we looked under a microscope, might we see that inflammation throughout their life in their airways? So did it really go away and come back, or was it always there and now it's just sort of flaring up? We don't always know the answer to that question. But it's certainly not unusual. What this person is asking about is not something unusual or worrisome. It's a very common pattern with the asthma coming back. And it doesn't necessarily mean it's going to come back in a more severe way later in life. Often, in fact, I think Mike was describing it was more severe in childhood. And then when it came back, it was less severe. So it doesn't necessarily mean that it's going to be the same or worse than it was.
And what was your experience? I mean, obviously, did it come and go?
No, not really. And I neglected to say that throughout my childhood, I did suffer from very bad chest and lung infections, but I was actually not diagnosed till I was 45. But Dr. Gupta and I had talked, and he believes that I was probably misdiagnosed or went undiagnosed. And so I probably did have childhood asthma. And then when I developed reflux, it started really playing up. But even then, I was not diagnosed. As I said, I was 45 before I was told I had asthma.
Oh, we have another audience question over here.
Just hang on.
My name's Goldie, and I'm a fundraiser. But that's very interesting. How common, Dr. Gupta, is it not recognized as the illness as asthma? Because I've always had chest infections, colds, sinus infections. In fact, my doctor for the first time suggested that I look into the heart, the stress test. And you were actually saying that it could lead into problems with respiratory with the heart. You said, yes, sinus infections. Yeah. But no one told me ever. And I pleaded one time when I was in my 20s. Please help me, doctor. I'm coughing, I'm sick, I get cold. No one ever said asthma, ever.
I'm wondering if, first of all, what comes to my mind is, did you ever have a spirometry test?
No, never, dear.
So to know if it's asthma for sure, the spirometry test is an objective measure.
Okay.
And I think that's what I would certainly ask your doctor to start with, is go ask your doctor for a spirometry test.
Thank you so much, thank you.
Dr. Gupta, did you want to add to that?
I think, what you're describing, an experience where you'll often sort of, people often present with frequent colds. You know, this might be an early sign, and what happens is it's just diagnosed as recurrent infections, but in fact, mild asthma might actually be manifest as an infection that sort of feels more severe than it should be or lasts longer than it should be. You know, a cough that doesn't go away and it lingers, or a bit of a wheeze or a tightness that lingers. And so, you know, sometimes patients don't have the classic textbook asthma symptoms, but their symptom is that, you know, whenever they get a cold, it lasts for an unusually long time. And that pattern in itself should raise a flag, but that's the kind of asthma that can get missed until someone sort of clues into that and says, well, let's do the spirometry and let's figure out, you know, could you have asthma? You know, maybe you're just unlucky and you keep getting bad viruses, or maybe this is asthma and there's more to it.
Mm-hmm. There's another question from a concerned parent in Vancouver who it reads, I'm concerned for my child with asthma and I do not want her rather, to take steroids. I only give my child medication when she needs it, but my doctor tells me to give the medication to my child every day. I do not see the need. Won't my child be fine when they're an adult?
So it's very tricky. What I would say is that, you know, in the medical profession in general, and this is what you see in all the asthma guidelines, the goal is to minimize the amount of therapy needed. When we talk about controller medications, we really are talking about everyday regular medications to control the asthma, to keep it maintained and to keep it at bay. And so, you know, in adults, but especially in kids, our goal is to get good control of asthma with controllers and then dial back on the dose. And sometimes we're lucky enough to dial back all the way to 0 and get people off their controllers in mild asthmatics. The challenge in terms of side effects, and I think, you know, with many parents, there are concerns, and that's fair, and particularly with steroids in kids, the biggest side effect we worry about is growth retardation. So kids not, you know, achieving the full height that they might achieve if they didn't require those inhaled steroids. But the flip side of the coin, and we always try to explain this to parents, is that we also get growth retardation from poorly controlled asthma. Asthma is a severe chronic disease. If that child is not breathing well, not getting enough oxygen, that child might also have growth retardation through that mechanism. The other thing is always about, I try to explain to my patients the notion of dosing. Again, we talked about these inhaled steroids being focused on the lungs, very little of that getting into the body and having an effect on the body. And those inhaled steroids enabling people to have a good quality of life, but also preventing severe flares. When patients get a severe flare, they often end up in the emergency room. And in that context, they will often require prednisone, or what we call systemic steroids. And what's happening then is that instead of taking this very small dose daily that's in your lungs only, you're going to get sick because you haven't prevented a flare and end up in the emergency room requiring a whopping dose of steroids. And at the end, you're the same or you're further ahead having taken that small preventative dose. So again, if the physician is recommending that we need to control this asthma with hopefully a small daily dose, then that's something that should be considered.
Mm-hmm. Did you want to add something?
No, I was going to say I completely agree.
We have time for 2 more questions, so let's go to an audience member now. Hello.
My name is Mary. I'm retired. I was information technology field, and I would like to know how to avoid the most common triggers of asthma.
Well, the most common triggers are going to really depend on what are your triggers. So for instance, I could say a common trigger for you know, Mike might be dust, might be pet dander, you know, might be cold air, might be air pollution. So what you need to do is, the most important thing for you is to identify what are your triggers. So what makes your asthma worse? And if you, what you could do is actually use a tool called an asthma diary that you could start recording, you know, times when your asthma does get worse, and then you make the connection to, oh, well, I was outside and it was cold and damp. Or, oh, I was visiting a friend and she had a pet. So it's really important to identify your triggers, because it's environmental control and identifying triggers is like the first step in managing asthma. That helps. Okay.
Then there's others that suddenly I'm not expecting, it's just caught short. And I don't know, those are the ones that really going about identifying those.
And do you keep your rescue inhaler, your bronchodilator on you?
Always.
Excellent. I'm glad to hear that.
One of the things that I've noticed, Carol, and I don't think we've talked about it this evening, is one of the triggers that I found, and this took a while for me to identify, was stress. And I'm not sure that too many people really realize that of themselves or even understand when they're under stress. And so what I've tried to do is avoid stress. I mean, in my particular case, I love music. You know, I will listen to music to try to calm myself down, but stress seems to be a big one. And it's something we found with our own daughters when they were young, that, you know, when you're a parent, you see your child under some sort of physical strain, you just naturally react with nervousness. And if you can avoid that, that seemed to help our kids as well. So I agree with you absolutely. It's a matter of identifying and trying to work with it.
We have one final question, and it's from a CART member in Winnipeg, and I think it's a really good one. And the question reads, as a society, how can we reduce the burden of asthma in Canada, including direct and indirect costs to our healthcare system? So it's a big question, but do you have any thoughts on that?
Yeah, that, you know, in fact,
We'll go around the table.
thank you to the viewer in Winnipeg, because that's the area that I do research in. And what we're talking about is, you know, how do we bridge the gaps that we have in asthma care? And we have very good evidence, we have very good studies, we have very good medicines, we have very good approaches like asthma action plans, but we also have large gaps in terms of utilizing these things in care. And that's, you know, that's across medicine, not just asthma, and that's because there's an overwhelming amount of evidence and data and studies coming at doctors, and it's hard to internalize all that and actually practice all that. And so what we're trying to do at a system level is to empower doctors to better implement that evidence at the point of care. And if we can achieve those goals and reduce those care gaps, the benefits are, you know, at the patient level, you know, so improved quality of life, less morbidity, even avoiding asthma deaths. But they're also at the level of the healthcare system. You know, in a healthcare system that's strained for resources, asthma, as we talked about, is billions of dollars in healthcare costs per year. And if we can implement the evidence at the point of care, reduce those care gaps, one of the big outcomes is reduced care costs in the form of emergency room visits, hospitalizations, things that burden the healthcare system in a major way that can be reduced significantly.
You know, when I heard your story, I just thought, oh, it's too bad that she wasn't diagnosed until you were in your 40s, you mentioned.
Yeah.
So it's incredible. Do you have any thoughts on?
I do. I think that, and I don't like to put any blame on anybody, but I had, in my time, I've been living in Canada for 42 years. So over those 42 years, I've had 6 family physicians, and my care was, I didn't go to a respirologist, I went to a family physician, and maybe they don't get quite enough training. Had they sort of understood it better, then it would have saved me going to emergency room, which puts an enormous burden on the healthcare. It would have also saved me getting so sick and putting another great burden on the healthcare system. But I'm also a true believer in the asthma action plan. And I think if we can get this across, it would be a huge stepping stone, because people can help themselves. I can help myself. I don't have to call Dr. Gupta now. I can, you know, I know the moment the warning signs come, okay, time to get on this medication and that medication. And now I'm able to control it. I'm able to stop it from worsening. And so I'm not putting such a burden on the system.
Makes sense to me. Carole?
I also feel that we need education at every point of care, so that if your patient is seeing your family doctor, if the family doctor doesn't have time to give the education, at least give the patient the resources of where to go for the education. Like you can speak to the Lung Association's certified respiratory educators, for instance. I also believe people shouldn't be walking out of a pharmacy with a bag full of inhalers and they don't know how to use those inhalers. So speak to the pharmacist and get the pharmacist to help you learn about how to use these inhalers. So I think education at every point of care is extremely important, because the more you get educated and the more you know about your asthma, learn about your triggers, and learn how to self-manage, you then decrease the burden to the healthcare system along the way.
I couldn't agree more. Final word to you.
Well, you know, I've always felt to a certain extent, and this is going to sound bizarre, lucky to have had childhood asthma, because it taught me, and my mom taught me, that if I need to go to a doctor, I need to go to a doctor. And I've never been afraid of doing that ever since. I come from a family that's reluctant to go to doctors. My feeling, you listen to your body, and if your body's trying to tell you something, don't be afraid to go see a doctor. This may have nothing to do with asthma at all. It may be something else. But if you think there's something wrong, don't be afraid to mention to the doctor, can I be tested for asthma?
Yeah, 100%. Okay, well, we're coming to the end of our time, but before we go, let's take a look at the current poll results. If we can pull them up on the screen, let's see what we heard from our members. Do I see them? Okay, so it looks like to the question, is your asthma well controlled? We've got over 53% that say yes. Oh, it's divided. 48% say no. I mean, that's pretty interesting. I mean, it kind of goes back to what you were saying earlier, Dr. Gupta.
The initial poll we did was 90% of people felt their asthma was well controlled. So maybe we'll take this as a positive in the sense that people are actually, being more critical and asking the right questions and noting that many people don't have well controlled asthma.
Yeah, well, that's interesting. Well, we'll continue to check on the poll, and we'll leave it up on our CARP website. So definitely go to the website and vote if you haven't done so already. And we'll continue to sort of check in on that, and we'll see the final tally. We've covered a lot of ground for World Asthma Day, so I'd like to thank our panel, Dr. Samir Gupta, Carole Madeley, Michael Nixon, and Alexandra Lennox. Thank you so much for being here. If you think that you've been suffering from asthma or need more information on how to manage, reach out to Asthma Society of Canada or Lung Association in your community. I'm Marissa Semkiw. On behalf of CARP, I'd like to thank you for joining us.